and I'm going to be talking to you about reasons why you need a chest tube, what it does, and the physiology behind the respiratory system. The human respiratory system is a negative pressure system. The chest wall muscles or external intercostals contract, and this elevates the ribs. The diaphragm also contracts and moves down, as you can see in this illustration. This causes the negative interpleural pressure, which causes the lungs to expand. Lungs deflate passively on expiration due to the elastic recoil, relaxation of the diaphragm, and surface tension of the alveoli, as you can see here. This right here is a attempt at an illustration of the anatomy of the lungs. This is the parietal pleura. In other words, this is the rib cage or the chest wall. The pleural space, which is in between the parietal pleura, and the visceral pleura, which is up against the organ, which would be the lung itself. The chest tube is placed into the pleural space, and a reason it would be there is because air or fluid could collect in the pleural space and cause a loss of the negative interpleural pressure. This results in a partial or complete collapsed lung, known as pneumothorax. Why can a chest tube be placed? Pleural effusion is fluid that escapes from surrounding tissues or lung itself and gets into the pleural space. A pneumothorax, which is air in the pleural space caused by trauma, or it could be spontaneous. Hemothorax, which is blood in the pleural space, also caused by trauma, disease process, blood clotting issue, so forth. Empyema, an infection in the pleural space. Cardiac surgery, which actually has its own type of chest tube. Or a chylothorax, which is lymphatic fluid in the pleural space. So what does the chest tube itself do? Chest tube is placed to remove the air or the fluid from the pleural space and restore the negative pressure environment, allowing the lungs to function properly. It prevents air from re-entering the pleural space via the systems that are used in its operation. It reestablishes, like I said, the negative pressure in the pleural space, and the lungs can re-expand and work again.
There are 3 different types of chest tubes. The first chest tube is wet suction. This is regulated by the height of water in the suction control chamber. Depending on what the physician orders is how much water you'll fill up the chamber with. You will hear and see gentle bubbling, and the water will evaporate over time. The second type of chest tube is dry suction. There is no water column to control suction, but uses a suction monitor bellow that balances while suction. Based on what the physician orders, you can adjust water suction pressure by using the rotary suction dial on the side of the system. This type of chest tube has higher suction pressure options, no bubbling of water, and no water evaporation. The third type of chest tube is the mediastinum space. This is placed under the sternum and drains fluid from around the heart after cardiac surgery.
Okay, the first thing I'm going to talk about is the scope of practice for chest tube insertion, removal, and management. As far as nurses are concerned, they are responsible for the care and maintenance, as well as assisting the provider with placement and removal, as well as any documentation pertaining to the color, type, amount, or consistency of the drainage. It is not to be delegated to UAPs. However, they may comment or document on findings that they observe, but any abnormal findings must be validated and interpreted by a nurse, and if necessary, reported to the physician. The second thing is preparation. You will first need to check the provider's order and verify that it is complete, and if necessary, check with the provider. You will then need to verify the consent with the patient, as it should have already been explained, the procedure that is to the patient by the provider, and then you will gather your supplies. If you are just maintaining a test tube, you should determine when the last dressing change was performed, and then there are supplies. You will need
sterile gloves, petroleum gauze, which are optional, a 250 milliliter bottle of sterile water, 4x4 gauze sponges, a complete drainage system to include tubing, skin cleansing solution, and the adhesive tape or foam dressing.
If the chest tube becomes dislodged, first, pinch the skin opening together. 2. Apply occlusive sterile dressing. 3. Cover the dressing with overlapping piece of 2-inch tape, then call the healthcare provider. If there is a cracked chest tube drainage system, first, disconnect from system. 2. Submerge the tube in a bottle of sterile water in order to maintain water seal. Caution: never do without doctor's orders. Follow hospital policy regarding clamping, which can result in an increased risk of tension pneumothorax.
Enter the room and introduce yourself to the patient, verifying their identity using the 2 patient identifiers. Perform hand hygiene and observe other appropriate infection control procedures. Provide for privacy and assess the patient. Determine the ease of respirations, breath sounds, respiratory rate, rhythm, and depth, oxygen saturation, and chest movements every 2 hours. Observe the dressing site. Inspect the dressing for excessive or abnormal drainage, such as bleeding or foul-smelling discharge. Palpate around the dressing site for crackling indicative of subcutaneous emphysema. Determine the level of discomfort with and without activity by asking the patient. Evaluate the impact of the changes to the patient's body. Implement all necessary safety precautions, monitoring for intactness of the closed chest drainage system and ensuring that the drainage system is below chest level and upright at all times. Maintain the patency of the system by checking to make sure that all connections are secured with tape. Assess the fluid level fluctuations and bubbling in the drainage system. Assess the drainage by inspecting the collection container at least every 15 minutes during the first 2 hours after the chest tube is inserted. Check every 2 hours thereafter. Watch for dislodgement of the tubes and remedy the problem promptly. When the procedure is complete, perform hand hygiene and leave the patient safe and comfortable with the bed low and locked, bed rails up, and call light within reach. Complete documentation using forms, checklists, or other electronic options. Enter the room and introduce yourself to the patient. Perform hand hygiene and identify the patient using the 2 patient identifiers. Assess the patient's pain using a 0 to 10 pain scale. Raise the bed and lower the head of the bed to facilitate an easier working environment. Drop the bed rail on the side which you intend to work. Then position the patient on their side. Don your mask and other PPE according to facility policy. Next, expose the site and then place a Chucks pad underneath the patient to protect the bed. Remove the dressing and note the color, consistency, and amount of drainage. Perform hand hygiene and don your sterile gloves. Next, clean the site with antiseptic. Using an inside to outside technique. Place the chest seal around the chest tube and cover with 4x4 pads, ensuring to tape all 4 sides of the 4x4 to secure them to the patient. Discard supplies perform hand hygiene, and document. If you suspect that the chest tube has come dislodged, it may be necessary to consult a physician and a chest x-ray may be ordered to verify placement. In order to set up the new dry suction chest seal unit, you will need 250 milliliters of sterile water, 1 syringe, and a new unit. You will first remove the cap from the water seal chamber, place your syringe to ensure no spillage, and instill the sterile water until the 2 centimeter mark is reached. You will then use the dial on the side to set the suction to the provider prescribed level. Replace the cap on the water seal chamber and setup is complete. To the room and introduce yourself to the patient. Perform hand hygiene and identify the patient using the 2 patient identifiers. Provide for privacy. Don PPE. Visualize the chest seal drainage chamber and ensure there is no leak in the air chamber by observing the orange suction control bellow is at the triangle mark. Raise the bed and position the patient on their side. Remove and discard your soiled gloves. Perform hand hygiene and don PPE according to facility policy. The chest tube near the insertion site. Disconnect the chest tube joint from the tubing. Reconnect the chest tubing to the new drainage system. Tape the connection to ensure it stays secured. Remove the clamps. Remove suction from the old system and connect it to the new system. Dispose of the old system. Have the patient turn, cough, and deep breathe. This should help loosen secretions. Make sure after you've adjusted the suction according to the provider's instructions, make sure that the bed is in the low and lock position. 3 out of 4 rails are up. The patient is comfortable. Call light is within reach. Dispose of any supplies. Perform hand hygiene and document the procedure and the patient's response.